I think we need to come up with a catchy jingle for the mailbag.
We get letters. That was somebody else's.
Check the mailbag. Ding.
Ding.
Okay. You ready for some emails from all over the globe? Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. So good to see you two.
You
Hello.
too. Hi.
All right, on the show this week, another edition of the mailbag. This is going to be so much fun. All of these questions are questions that we all have wondered at some point in our metabolic journey. So what do you say? You ready to jump in?
Ready.
We get lots of letters. We get lots of letters.
Here we go. All right, the first letter, Dr. Cooper, from Carrie. I've been listening to your podcast for a few months. I really appreciate all the insights you share. I recently started Zepbound and am on my 4th dose of 2.5 milligrams. I have several health concerns, including high cholesterol, OSA. What is OSA?
What's that?
Obstructive sleep apnea.
Oh.
Okay, OSA, joint pain, and now perimenopause. What's the definition of that?
That's the time frame before you're full-blown classified as menopause. Menopause, you have to have no menstrual cycle for a year and have your labs show that you're in menopause. Perimenopause can be like a 2-year period before that, where your hormones are on a roller coaster up and down, going from really strong to very weak to very strong to very weak. And we're talking about estrogen mainly and progesterone.
Okay, great. Carrie goes on to say, I'm already experiencing relief while losing about 8 pounds. Again, she's on Zepbound. My question is about eating when you're hungry versus eating mechanically. My whole life, I've heard it's best to eat mindfully and follow hunger cues. And so far, I still experience some hunger on Zepbound, so I eat when I feel it. But you've mentioned mechanical eating. Is that mainly for those on higher doses who no longer feel hungry at all? I'm also struggling with how to eat to avoid, quote, starvation mode while managing the side effects of bloating and burping, reflux, feeling overly full. Carrie says, right now I can only eat about half of what I used to. I'm imagining I'm consuming about 12 to 1,400 calories max. She's 45, 5'7". People on this medication seem hyper-focused on keeping calories low. What's the best approach for fueling my body properly while respecting the limits Zepbound creates? Lastly, I assume I'm going to hit a plateau at some point. How do you recommend getting past that? My main goal is health. I felt my best around 150 pounds. Thanks so much for all the work that you do. And that is signed, Carrie. What a great, thoughtful email, Dr. Cooper. So she's on Zepbound. Refresh us what that is.
Yep, Zepbound is a dual agonist, so it's GLP-1 and GIP affect much more GIP impact than the GLP-1 in that medication. And it's prescribed for BMI above 30 or 27 or higher with comorbidities, which means comorbidities would be the obstructive sleep apnea, for example, cardiovascular risk, insulin resistance, prediabetes, any of those, hypertension. So it's the newest of all of the medications that have been out to treat obesity. And it is a breakthrough medicine because it's the first one that's a dual agonist that isn't just mimicking our body's GLP-1 hormone, but it also mimics the GIP. And those are two what are called incretins that are gut hormones that inform our brain that we have enough food, basically. So they do impact the appetite because those signals in the brain can be strong. And people assume that's the way that they work is just by making a person eat less. But it's not really true. They have a lot of metabolic effects as well that strengthen our metabolism and enable our metabolism to function more normally and more optimally. And so one of the concerns is that because they impair the appetite to varying degrees, if it's a really strong appetite suppression, it could actually lead to nutrition imbalances, nutrition deficits, and a sense of the body that there's just not enough food coming in. And then that detracts from the effectiveness, actually, of the medication eventually. So what you want to find is how much medication should a person be taking to keep in a range where the side effects are not so strong that they're affecting daily quality of life, or they're affecting the amount of food somebody can eat, and that you can still make progress at. So Carrie mentioned that she's on 2.5 for 4 weeks and lost 8 pounds. I mean, that is a very fast weight loss rate. People don't really understand what a normal weight response would be, like what you would expect of a weight response. But that is very fast. So, according to the prescribing information, a lot of times people will say, stay on 2.5 milligrams, which is the lowest dose, for a month, then go to 5 milligrams. But it was good that Carrie sounded like she wasn't going to be increasing the dose. She was just waiting to see what happens, which I think is a great strategy if you're already responding at that rate and you're already having side effects, basically. So the point is of learning to manage these side effects. And so, as Andrea always says, there will be some side effects for most people initially. That is the case. I think it was like more than 65% of people had reported side effects with these drugs. So it's the most common thing is to have side effects. And I think that everyone can live with just a little nausea or little stomach discomfort, a little change in appetite. But once it starts getting to be more, and if there's vomiting or there's diarrhea and there's like inability to eat, that starts affecting quality of life. And so that could impact the food intake. And so the key is figure out the dosing that enables you to feel your best still and to be able to consume food on a regular basis. But because there's that interference, we find that mechanical eating is more reliable than what's called intuitive eating or mindful eating. I get it. Mindful eating and intuitive eating are a good concept because it just means pay attention, when you're eating. Don't eat mindlessly and not even realize you're eating. Focus on what your body cues are telling you when you're eating. And we all should be doing that, most of the time. But unfortunately, when you're on these meds, they naturally do suppress some of those cues. And so can we still rely on the mindfulness? Can we still rely on that intuitiveness of what we should eat? Maybe not, because maybe that would lead you to skipping meals or eating very little amount of food. And next thing you know, you're losing weight, but you're losing lean mass too. And you're starting to feel tired. Your blood sugar's starting to feel shaky. Your focus isn't as good. So, and the medication won't work as well. And so I think the mechanical eating is so helpful really for that. So it doesn't mean that it's controlling everything that you're eating. If you go to mechanical, that it's replacing all of your intuition. The key is if you use mechanical just simply for the frequency that you're going to eat throughout the day and the food groups you're going to include. Use that to be the mechanical part of it. And so that means, okay, within an hour of waking, I'm going to have my breakfast, and then I'm going to eat every few hours throughout the day while I'm awake, alternating meals and snacks. That way, you're sure that you're not going to get into those deficits that would be concerning to your body. And the other aspect of the mechanical is just to include all the food groups throughout the day. And when we say all the food groups, we are including starches because people think, almost everybody that's been dealing with high weight conditions is a little bit carbophobic. Mm-hmm. So we want to have the starches in the diet. And yes, it is always good if we can eat whole foods. It's just good for our health. So whole grains, beans, legumes are starches and starchy veggies. But it doesn't all have to be this high fiber type of eating, because one of the concerns is if you eat a lot of fiber, your stomach is going to fill up with the fiber, and then you'll really feel like you don't have an appetite, and then you may end up in a further deficit. So it's good to have a mixture of things, not a lot, not like a huge amount of fiber. And again, we're not dietitians, but we want to try to at least give these practical tips of how to navigate the side effects of the meds and getting enough fueling. So I think that's one area is the fiber. The other is drinking a lot of fluids with your meals can make your stomach get a really strong fullness sensation. And then that could block your ability to eat enough. And so we always advise our patients to drink their fluids between meals, primarily, like they're large amounts, other than sipping fluids with meals, just to try to avoid that filling up on fluids and tons of fiber, because that is no doubt going to lead to more difficulty with side effects and with inability to get enough calories in.
Yeah. She says she's eating probably around 1,200 to 1,400 calories a day. Does that sound too low to you, Dr. Cooper? And what's the danger if you don't eat enough food in a day?
That's a good question. Well, and when we're doing all the food groups, we still need our protein and we need our fats, as well as the starches and the carbs and all that, and we need all those. So, are we getting enough to hit when you're at 1,200 to 1,400 calories? Is that enough to get those requirements in? For most people, it wouldn't be. Now, one thing to think about is when you're in a strong, body fat loss mode, that body fat is providing fuel to your body to use as energy. So that is one of the reasons you're not as hungry, because your body it kind of sees that fuel that it's releasing out of the fat stores for energy. It sees it as a meal, basically. So it sees that amount of calories that are being liberated from the body fat as fuel. And so that would reduce your sense of how much you need to take in through your diet. So that is one thing to keep in mind. So that's why some people can get away with not eating a huge amount, or not eating, I shouldn't say not eating a huge amount, but can get away with some level of reduction of their caloric intake. So when your body is able to tap into the body fat for stores, it may not realize right away that you're under fueling it because it's able to get that fuel from the body fat stores. But after a while, things start altering with your glucose and insulin levels, your leptin and other hormones that start signaling the brain that you're not fueling adequately enough. And so I think the mechanical eating is just the best way to do it. And then being on this 1,400, 1,200 calories a day isn't really going to be great for long-term success. Even before I got into working with people with high body weight, what I noticed when I did metabolic testing in athletes and people that were just coming to try to improve athletic performance, it's the more that you would eat, the faster your metabolic rate would go, basically. And the less you would eat, it just adapts and slows down to that level. And nothing would change with the body weight. The body weight would be the same regardless. So I've always had that in the back of my mind, that I've seen that just so much clinically that I use that same approach with people with high body weight. It's like we want to eat at the top of our caloric intake that will keep our metabolism going, not at the bottom where it's slowing it down because it's trying to match what we're eating. So we're not talking about overeating, but we just want to make sure we're fueling enough. And we didn't even talk about whether Carrie is exercising, but of course, if you're exercising, that amount of calories is not going to be enough to support exercise either. And so I would think about working maybe with a dietitian if you're not clear on it. We try to get away from counting calories and things, but it's not about trying to feel over full. It's just get into the mechanical eating process, making sure you got the food groups, making sure you got the timing, and then pick what you want within those parameters. And, if you really have a low appetite, you probably should work with a dietitian and just see how could you boost that up to make sure you're hitting your protein goals, your fat goals, your carb goals to support whatever your lifestyle is.
All right. And also, Carrie is still in that adjustment period. She's only been on the meds for a month, so her body's still trying to figure this whole thing out. And I'll tell you, Carrie, I got up this morning. I didn't feel like eating breakfast. I really literally had to force myself to make an egg and a piece of toast and some cheese toast. I didn't feel like it, and so I think sometimes you just have to. You have to get over it.
Right. You have to figure it out. What I've done, I mean, my little secret thing that I've worked with my dietitian is, because when I wake up, I don't really feel like eating, like Mark said. I have a protein drink that I mix with my coffee that satisfies what I call breakfast number one. And then for breakfast number two, I have what people would call it a real breakfast. Then I have like an egg or whatever for breakfast number two. Around 10:30, 11 o'clock, I have breakfast number two. So at 7:30, I have breakfast number one, which is the protein drink.
That's awesome. Well, Carrie, thanks for listening. Thanks for the email. And good luck. Keep us posted how you're doing.
Okay, question number 2. Hello, I started listening to Fat Science podcast and shortly thereafter signed up for an evaluation at SPM, which is Dr. Cooper's practice. I'm currently a patient there and I'm hopeful about the outcome. I have a podcast topic I'd love to hear. The emotional responses to learning to eat more frequently, which it sort of relates to our first topic. I'm finding challenges that I didn't expect in this area, such as feeling worried, anxious, and guilty. Ooh. This could also be discussed in the context of fat shaming in our society and how that's integrated into a person's sense of self, especially around food. I can't be the only person to experience this. Ask Andrea. That's me. She'll tell you. I bet she has a ton of stories, and I bet that Mark and Dr. Cooper also have heard of or experienced these kinds of things. Thanks so much. Keep the great podcast going. Kate.
Wow, that is good.
Well, let's see. I guess she wants to refer to eating lots of meals all the time, and I guess that means like eating in public or the fat shaming of like eating around people all the time. Have I experienced fat shaming many, many, many times? I wouldn't say it was necessarily, well, maybe it is around like eating because you're fat and you're eating
you told
around
me all
people.
about
Yeah,
holidays.
like holidays. People always saying things like, oh, you're going to eat that pie? You're going to eat that, all those desserts? Yeah, I would say that there's that, but it wouldn't be necessarily around this particular topic, but the fat shaming around eating food in general all the time, because people always would look at your plate and then look at you and look at your butt and look at you and look at your butt and look at you. And I mean, I never was an overeater. I never ate tons and tons of food. I never was that person who ate like, although maybe a pint of ice cream I did consider a single serving portion, but I never was the person who ate like 18 cakes and 8 bags of chips or something like that. I wasn't that person, but I always did feel like, you know, like when you're in the food court at a mall or something, people looking at you going, there's that girl eating a hot dog. She probably shouldn't have that. And you're like, what, I can't eat because I'm like fat or whatever. You know, you do always feel that every mouthful of food that you're eating, people are staring at you going, she shouldn't eat that. And it really is kind of a sick society that we have, that we feel that way.
But I think what Kate's getting at, and what you've told us many times, Andrea, is that when you are dealing with a weight issue, food is the enemy.
Always.
I mean, everyone, society, doctors, everyone is telling you that too much food, that food
Any
actually
food.
is
That
the enemy.
It's not even too much food.
Yeah,
Any
it's just-
food.
and so-
when you're walking by the food,
Right.
you can almost hear the food yelling at you, eat me, eat me, eat me, and then like mocking you, basically going,
And so
haha,
Kate-
you can't have
Kate's
me.
feeling worried and anxious and guilty at times, Dr. Cooper, because that old thought process is still in the back of
And
her mind.
the old food process of saying, don't eat so much, probably. I know that like sometimes I'm like, oh my God, I'm eating all the time. I'm carrying around food with me all the time.
Yeah, I know. You know, what's really sad hearing all this, I can't believe how much it mirrors. I hate to keep bringing up like eating disorders like anorexia nervosa. I cannot.
It's the same thing.
It is that sense of like, I don't deserve to eat this. I shouldn't eat this. It's like, I have to have this willpower to not eat this. And it's crazy how similar the the psychology is between a full-blown disorder like anorexia nervosa, which is like a serious, life-threatening condition, and people with high body weight and how they feel internally, emotionally about the eating, like the relationship with food and the relationship with eating, and the shaming that goes on in our society.
You're embarrassed at every turn. You're embarrassed when you walk onto a plane and every single person stares at you going, oh my God, I hope she doesn't sit next to me. I hope she doesn't sit next to me. The fact that I have to say, one of my most triumphant moments was when I walked onto a plane knowing that I didn't have to have a seatbelt extender to sit in an airplane seat, that I didn't need that and could just sit in a seat without having to use it. It was like such a joyful moment.
Because of the anxiety
The anxiety.
Yes. It's not because like the seatbelt extender wasn't useful.
Well, I had my own. Because when you have to ask the stewardess for one or the flight attendant to have one, and they have to reach across the people because I sit in the window seat, it's like your blood pressure goes up, your heart goes up. Or when I would have my own and you sit in the airplane seat and they have the different kind of seatbelt that you can't have your own seatbelt extender. It's that other fancy kind of seatbelt, so you can't have it. So then they have to bring you a special one, and it's like a whole to-do in the airplane. It's like the most mortifying, horrible thing. And everybody knows what's going on. They're like, oh, now what's going on? It's a horrible thing.
So, Dr. Cooper, what's your best advice to Kate as she makes that transition? And I think all of us with metabolic issues, I had to make that transition. And I remember coming to you and talking about it, and you said, look, if you want to have dessert and don't feel bad about it.
Right, exactly. Yeah, I think that it is a matter of figuring out, remembering your priorities, remembering your goals, remember why you're doing this, and establishing a new relationship with food and your body, where it's about fueling your body and being grateful to your body for being able to use that fuel to do all the amazing things that it can do. And how do the emotional scars, of dealing with our society and the fat shaming and the sideways looks of people, there's not a whole lot we can do about that, honestly.
They don't go away.
But I think that we have to be strong enough. And again, taking it from the inspiration of people who had, full-blown anorexia nervosa, a serious eating disorder, life-threatening, that felt the exact same thing, as amplified, maybe even more. And their life depended on being able to break through that and stick with what they're doing and believe in it and believe that they had to eat every bite of that food in order to gain their health back. Look at that inspiration, because it's not that different. It's not any different. It's a person that's dealing with this high body weight, that has dieted all their life, has been on this restrictive eating, has been thinking so much about every bite in their mouth and every bit of the step of their exercise, and second guessing and blaming themselves and listening to others blaming them. That is just horrible, but we've got to rise above it and have a different relationship, a brand new relationship. This is fuel, just like every living thing needs fuel. I need fuel. And doing the mechanical eating takes away a lot of this whole options and guessing, because that can create more anxiety for people that are dealing with this emotional piece. So to get away from that, have this mechanical eating structure and maybe do some food planning with a dietitian, because that way, that's what we do with people who are recovering from anorexia nervosa. We have them on meal plans. So they don't actually even they don't have a lot of options. It's like you either are going to eat this or you're going to eat that. for your meal, your breakfast, and then you're going to eat this or that for your lunch, and you're going to eat. And a dietitian helps set those up, and that takes out a lot of the overthinking in the beginning, at least. So I highly recommend that, because I worry about someone that's as affected as this with the emotional piece, that it may be too tough to make the decisions 5-6 times a day of what to eat and go through that anxiety. So in the beginning, at least, I would definitely think about creating a meal plan with a dietitian and let them take over of, making sure they're building a program that's going to keep you fueled well, and they work with you on it. So it's foods that you would like to eat. And maybe you could move on from that to even maybe a food delivery service, to again, take away all this having to think about it so much. And then maybe you'll become free after that to be able to trust yourself and trust the experience and enjoy the experience. I'm just thinking of how for some people it is that extreme emotionally, that taking away all of every time you're going to the fridge, should I eat this? Should I eat that? And the guilt and the shame and the weird emotional reactions to it. Sometimes it's good taking that away and just be like, oh, this is what I've been told I need to eat, just like we do with patients with a full-blown eating disorder.
Well, Kate, thank you so much for the email. Good
Thank
luck
you.
on your journey. Keep us posted. Okay, our final email is from Shalini in Nashville. Dear Dr. Cooper, I've been successfully treated for an anxiety disorder with antidepressants and antipsychotics over 30 years. When I started on Zepbound, I noticed my anxiety returning on day 2 and 3 after taking my shot. This has been very worrisome. The antipsychotics have completely stopped my metabolism and have caused immense weight gain. I was really hoping Zepbound could counter that. Is this something that will go away in time? I follow some GLP-1 users on Reddit, and it seems this is an issue others have experienced as well. Do GLP-1s disrupt the absorption of medications like antidepressants and antipsychotics? Thank you. And again, Shalini in Nashville with that question.
That is a great question. That's excellent. It's possible. It's possible. It's possible. There's a few things that could be going on. First off, the antipsychotic meds are so valuable and so helpful, but they are real harsh for the metabolic system. And so they lead often to weight gain, real bizarre appetite dysregulation, blood sugar imbalances, insulin imbalances, ghrelin imbalances, all kinds of stuff. But they do a good job for many people for mood regulation. So, but it is interesting that remember that when you dose one of these meds, the GLP-1s or the GIP GLP-1, it has a 72-hour period after the dose that the level in your system is increasing. And so the highest levels are within that first 72 hours. And so what's interesting is, the noticing of that, some change there. So my thought is, it's a really good observation that it could be affecting the absorption of the antipsychotic meds. Very good observation. It's very possible because they can slow the GI emptying and affect absorption of certain meds. Although the Zepbound has less of an impact on that because it doesn't slow the GI motility as much as others do. But I would actually put that to your doctor and your pharmacist, because I don't know which meds you're on, and I haven't had time to research which ones it might affect. The other thing is a lot of psych meds, you can order blood levels for them. So you can actually monitor the blood levels. And so that would be a good thing, is to do some labs to find out if the blood level is dropping, and ask the pharmacist to investigate whether there's an interaction there. But aside from that, if that turns out not to be the issue, this sounds very suspicious that it could be related to one of those problems that we've talked about before, where there's more than meets the eye going on with the metabolism, and that there's something else going on metabolically where the Zepbound might be making a certain type of correction, but not correcting another aspect enough. And because of that, it could be throwing your blood sugar off. And you could be developing something like hypoglycemia episodes, because hypoglycemia causes anxiety typically, because it increases our body's production of something called catecholamines, which are fight or flight chemicals in our body. And the reason it increases the catecholamines is because we need the catecholamines in order to rescue a low blood sugar from if it's happening in our system. So these anxiety bursts might be related to a low blood sugar reaction that's triggering catecholamine production. And so that would be really important to do what we've always talked about, these meal tests, where you check your blood sugar, not just fasting, but after eating a meal. And ideally also check the insulin. But that's my thought from hearing this. It sounds suspicious for one of two of those possible causes.
That's really interesting. Dr. Cooper, when I know from personal experience, when I've had blood sugar crashes, that it gives you that anxious, shaky, unstable feeling all by itself.
It really does. And it can make your heart race and give you palpitations and things like that. Almost feel like an anxiety attack, like a panic attack.
And I didn't know that they were stronger for the first 3 days.
Yeah.
Oh, it's interesting.
After you've been on them a long time, it does level out, but usually that first 72 hours, they're stronger.
Huh.
Well, Shalini, thank you so much for listening to the podcast, and keep us posted. Let us know how things go as you talk with your doc and try to move through this. So, all right. Any final thoughts from the panel?
Well, I think we've all learned something today.
Yeah, I love these questions. I really feel like, because we try to come up with these topics, but the questions that people present are just such important questions to answer. And so I'm just so happy that we're getting this mail.
Yeah, I think we need a new word for mechanical eating. It sounds so robotic. I don't like that.
Robotic eating.
I don't like. I just always think of it as like eating many times a day. I don't.
Yeah,
know.
that's what Mark always calls it. Timed. What do you call it?
Timed?
Not timed eating, but you call it.
I can't remember what
sequential
I call it.
or something. Sequential eating or
Yeah.
something.
But yeah, mechanical eating sounds like I am
sounds like-
going to eat cereal now.
Yeah, and it sounds like there's like a robot in my house, like force feeding me or something. I don't know.
All right. We'll come up with something else.
I know, but that's what it's called. And it just seems so. It seems so negative. I don't know. I like my mini meals. I like my little meals. I always tell people, and the dessert thing always makes people like, you're going to eat dessert and you're losing weight. I'm like, yeah, that's how it works.
It happens all the time. I'll be out to lunch with some friends or whatever and take the burger without the buns, skip the dessert. I'll have, and it's just pervasive. But I think what we said at the beginning of this episode is that all these questions speak to things that we have wondered and had to deal with in our own journey, especially when it comes to mechanical eating, especially when it comes to how we perceive food and all of that.
Right. And the fact that, it's so funny because everyone is like, I guess it kind of goes into a fat shaming thing, and I just don't think of it that way when people go, oh, you just eat all those little, you don't eat anything anymore. You eat tiny amounts. And I'm like, yeah, but you know what? I eat the other half of this food when I go home after, we're done. In a couple hours, I'm going to eat again. Guess what? I get to eat again. And I have dessert. I have all these things. And the weight is still coming off very slowly. And I don't think about dieting. I do think about dying. But I don't think about dieting. I love food more than anybody probably that anyone knows. And I enjoy every mouthful, every bite.
Yeah.
And I just eat lots. But
I think fueling your body regularly builds confidence and self-love and all the positives, really. So there's nothing negative about it, really, ultimately, if we can work past any of those emotional barriers.
That's good stuff.
Yeah.
If you have a question for us for a future edition of Mailbag, info@diabesityiinstitute.org. You can also send us questions to our personal addresses, dr.c@fatsciencepodcast.com, Andrea at fatsciencepodcast.com, or Mark at fatsciencepodcast.com. We'd love to hear from you. And those are great ways to connect and put a question to us. Or if you have a suggestion for a future episode of Fat Science, that's the way to get to us as well. Well, this has been fun. Thanks, everybody, for listening. And also thanks to those of you who wrote in with those amazing questions. Another edition of Fat Science.
No diets, no agendas, just science to make you feel better.